standing, turning, and so on. These are simple tasks for all of us. However, think of someone who has had a recent stroke, or a spinal cord injury, or born with a cerebral palsy, or older adults. These simple motor tasks become a challenge for them. There are usually no pills that you can take to regain these functions. Motor practice is the prescribed medication, and it requires time and intense practice. The scientific framework behind motor practice is neural plasticity. The nervous system has the ability to change its activity in response to its intrinsic or extrinsic stimuli. Practice reorganizes the structure of the nervous system and its connections. Motor principles that are used in retraining of the nervous system include progression, repetition, and challenge. So our robotics and rehabilitation laboratory at Columbia University uses robotics to measure movement of the human body and apply appropriate forces on the segments to change the difficulty level and train the nervous system. I'll give you a number of examples today in my talk today. Our robots are like the training wheels on a bicycle when children are learning to bike. The children use these until they improve the skills, and then they throw these away. So this is how we see these rehabilitation robotics. So let's kind of go through some concrete examples. So in the United States, there are about 7 million survivors of stroke, right? And I'm sure that there is a similar ratio here in India as well. A clot develops in a blood vessel, and blood supply to the brain gets affected. Survivors of stroke continue to have weakness in one side of the body. They walk with a limp, and on the weak side, they have a foot drop. They drag their toes and hike their hips to clear the ground. So in order to rehabilitate people with this impairment, we developed a robot called ALEX. It's an acronym for Active Leg Exoskeleton. And it applies assist-as-needed forces to help the subjects to walk. And of course, there is an important engineering design process. We are not going to get into that today. But with these devices, the subjects underwent 15 training sessions over 6 weeks. And overground walking speed was one of the outcome measures after your training was finished. And what we were able to show that the overground walking speed for a group of individuals who were trained with this robot, they were able to improve their walking speed from the baseline to the post-training. And the group retained these changes 6 months later and even further improved it. This is consistent with published works in stroke rehab. Once the change is initiated in the nervous system, the participants further improve it with practice. Subsequently, our group created and tested other exoskeletons like ALEX 3, which is a bilateral exoskeleton, a cable-driven exoskeleton, where cable tensions are controlled to apply torques at the joints. And this is motivated by puppeteering, where puppet masters are able to move body segments around. So all these machines were tested with stroke patients. And in fact, these are all published works that you can look up if you're interested. And these demonstrate the efficacy of these technologies. And there's a potential to bring these technologies to the global market, because stroke is not something that happens only in the United States, but there is about 2 to 3% of population in the world actually is living with after effects of stroke. Let me move on to another group of individuals. So cerebral palsy is a brain impairment at birth and affects about 500,000 children in the United States. It is a lifelong condition. Many children are on wheelchairs and have deficits in trunk control. We created a trunk support trainer, we call it TRUST, and you'll see that in operation and some of the studies that we have done with these children. And what it does is it simulates forces applied by a therapist's hand using motors to help retrain the trunk movement. Now here is data on the left that you see with 3 children who were trained with this trust across 12 training sessions and with a 3-month follow-up period. The plot shows how the workspace area changed across the training and evaluation sessions. Children progressively expand their sitting workspace during and after trust intervention. Okay, not only does it improve, no, sorry. Can we go back, please? Yeah, and just,
We came from Florida, so it was a long way. Everyone here is so kind, made her feel so at home.
I liked all the games.
She plays a lot more with you guys, doesn't she?
She can throw balls better.
If she's eating, she would be able to stand up on her own and then reach over the table and grab some stuff. And she used to not do that at all. And she does her hair in the mornings now.
well, as you saw, not only does these devices improve the workspace of these children, but also affects the children in their daily tasks. For example, you heard from one of the participants that the child could actually comb her hair. And if you were to think back a little bit, combing of your hair really requires a lot of your trunk activity, which these children did not have. So let's go on to the next segment. Okay, and this is about patients with ALS. So there are about 20,000 people with ALS, which is also called amyotrophic lateral sclerosis, in the United States. And ALS is a neurodegenerative muscle disease. Some of you may remember Stephen Hawking when he was alive. One of the challenges that ALS patients face is head drop. That means the inability to move your head around, just like what you are doing right now. And this affects their ability to swallow, breathe, and communicate socially in the dropped head position. So we have developed these robotic neck braces that allow to characterize the motion of the head, neck, along with measurements of the electrical activity of the muscles. The assist head-neck motion in patients with ALS to mimic motions, as you are seeing here, the patients are mimicking the motion of an avatar on a screen, but by themselves they cannot control the motion of the head. So let me kind of move forward here. In this video, I would like to share with you the results of a study that we have done with Parkinson patients. According to data from Michael J. Fox Foundation, there are about 1 million people in the United States who are living with a Parkinson's disease, right? And I know that this ratio, 1/350, is even higher in India compared to the United States. Now, patients with Parkinson's disease show poor balance control, including something called freezing of gait. So what we did is, I'll show this video here, we call it a T-pad, and I'll give you just a little preview before you can see the video itself. So T-pad was programmed to deliver force perturbation pulses randomly in 4 directions: forward, backward, left, and right. And the intensity of the perturbations was increased in each training block. The results show that Parkinson's disease patients increase their stability similar to healthy controls. So let's see the video.
It looks a little like Harry Greenwald is getting ready to go skydiving, or maybe bungee jumping. But this is actually part of a study to prevent potentially serious falls. Very important because Harry has Parkinson's.
There have been times when I could feel my forward foot not quite grasping the next tread on the stairs. And there are times when we're walking down the sidewalk, I have to remind myself, for posture issues, I should be raising my head and looking ahead because Parkinson's has got me looking down a lot.
40% of people over age 65 suffer a fall at least once a year. That number is much higher for people with Parkinson's because the disease affects their gait and balance. So Dr. Sunil Aggarwal at Columbia University has devised a system to teach Parkinson's patients how to keep from falling by training them to recover when this elaborate contraption tries to disrupt their sense of balance.
We give them the experience of being able to recover better from this momentary loss of balance and be able to train their neuromuscular system to be able to be more responsive when a fall appears.
In fact, Dr. Aggarwal's study showed that just one training session substantially improved Parkinson's patients' balance and ability to avoid falls. The harness prevents Harry and others from actually falling, of course, and the better they get, the stronger the jolts come, and from different directions. Although Harry had to learn to trust the device.
I relaxed a little and said, okay, I'm not really going to hit the ground here. Hey, it works. The harness really is going to keep me up.
Now, Harry says he's more confident now walking and especially going up and down stairs. The balance disruption system is just at Columbia for now, but it could be rolled out to other medical centers. You only have to prevent a couple of serious falls in Parkinson's patients to make it all cost-effective. You learn.
So, as we saw here, imbalance and falls is quite common in older adults. These occur with decline in the quality of the sensory signals or due to inability of the central nervous system to integrate these signals properly. According to the Center for Disease Control in the United States, there are about 69 million people in the United States who have sensory dysfunction. In our daily life, we waste signals from our eyes, ears, and muscles to estimate our pose in space. When walking to the toilet in the night, we rely more on the vestibular and proprioceptive signals. In addition, dual tasks, for example, walking while talking on phone, they take away our cognitive resources from the brain reserved for that walking activity. And we can use the head neck brace, as you are seeing here on the picture here. So let me just kind of, okay, please go back one slide. Yeah, if you can go back to the previous slide, please. Yes. So we can use the head neck brace and virtual reality to introduce controlled noise within the sensory channels of our sensory system and evaluate how this affects balance and gait during walking. And this slide shows the results of an experiment where a group of young participants and elderly subjects from the community walked under two conditions: oscillation of the head. Okay, maybe we can go back here, please. Oscillation of the head or combined oscillations of the head and visual perturbations. Our results showed that older adults have higher variability in gait and balance parameters compared to young adults, to both head oscillations and head visual oscillation condition. These experiments can help discriminate patients and explain their particular sensory deficit. Vestibular rehabilitation is important in geriatrics, where robotics can play a strong role in the future. So let's come to this slide here, which is already on the screen. Okay, we know that when children are growing, so think of an infant who is 6 months old, right? The self-generated mobility is important for their development. This development is multifaceted. For example, spatial awareness, visual perception, posture, and social interaction. Now, these special needs children, there are special needs children who are born with cerebral palsy, or Down syndrome, or autism. And many of these children have delayed development due to lack of motor or cognitive ability and miss out on the developmental milestones. So our thought was, why not bring some of these technologies, such as robotics, to bear on these children. And these are 6-month-old babies, and we wanted to see if they will learn to drive a robot, right? And this is the first time when you put the baby on the robot, the baby really doesn't know the association with this joystick and being able to move around. However, if you are persistent with the child, okay, you will see that very soon they would learn to drive the robot by themselves. So these are 6-month-old babies, and you have to keep that in mind. And what this mobility does is allows them to be around in this environment. In fact, we have done a study with almost 25 babies, right? And what we were able to show that these babies can actually learn to drive. I mean, you show them a toy, they will come down and drive and come to you. But the goal here is not just to kind of show them this ability to drive around, but to see how we can integrate these babies within a social environment. For example, one of the studies that we did is we took these babies who are with cerebral palsy and tried to see if we can integrate them in a classroom, right? If you think of a typical classroom, all of these babies all the kids with impairments are sitting in a corner while the rest of the class is doing their wonderful things. And the goal was that through this mobile technology, how could we actually integrate these children within the classroom and eventually in the society. So a few takeaways that I have from my talk today. Okay, according to the World Health Organization, there's 1 billion people in the world who need assistive or rehabilitative technologies, right? So it's a big number that we see around here. Now, we also know that the elderly population, which is typically defined as 65 years or older, is expected to double in the next 25 years, right? There'll be more people among us who are older individuals, and there are less people who can take care of them. And that's where the technology comes in to fill that role. And this longevity brings many challenges in terms of the quality of life. Now, in my talk today, I give you statistics about what happens in the United States. But it turns out to be that these impairment statistics are very similar all around the world. I mean, we have some colleagues, we have some close colleagues who we work with in Africa with cerebral palsy, and we know that some of the numbers for them are a little bit higher than what we see in the United States and the typical developed countries. So all of these ideas and technologies that I am describing to you here can actually be adapted, right, to the Indian scenario or to the Asian scenario or to the African scenarios and so on. Now, we also saw that small improvements in daily function can result in significant improvement in quality of life, right? If you think about that girl who was able to stand on the table and reach out for food, right? What we did was really a training in terms of her ability to move around and move her trunk. But that increased her quality of life, being able to comb her hair or put on a t-shirt, and these are big milestones from the child's perspective. Now, as you may have seen robotics as really a vehicle into manufacturing, right? And so I'm a roboticist by training. Now, robotics, of course, has made big inroads in manufacturing, right? But I think the time is right for the robotics to take the next step, right? Not only to facilitate what happens out in industry or making some of these autonomous machines, but it can be sort of wrapped around the human body, right? What could be more important, right? We as citizens or we as people to see how we can create technologies to help the people and the loved ones. Thank you very much.
Thank you so much, Professor Aggarwal, for that very futuristic and, of course, also thought-provoking address and presentation. Okay, we are going to, of course, be quickly now turning our focus to our next segment today, which, of course, is going to be part, of course, of the Next in Global Affairs theme and, of course, special segment. To talk specifically about the future of BRICS and more, we are very, very privileged now to be joined